الرحمن الرحيم. السلام عليكم ورحمة الله تعالى وبركاته. This is our lecture on parathyroid surgery. It is going to be a lengthy lecture and it have to be looked after very carefully. The parathyroid is an important endocrine structure which is having the outline of the lecture. We will talk about the anatomy, embryology, and physiology. Sometimes we are going to discuss the pathophysiology and the clinical presentation as far as the diseases of the parathyroid, how it will present in history, examination, and investigation. What are the indications for surgery and what are the complications afterwards. The parathyroid gland are 4 in numbers and they are situated at the back of the thyroid, 2 inferior and 2 superior, 2 on each side with the left and right lobes. And embryologically they develop from the 3rd and 4th pharyngeal pouches. The inferior one developed from the 3rd pharyngeal pouch and the superior one from the 4th pharyngeal pouch. It's very small. It's like the grain of lentils. It weighs about 3 to 5 grams. If it is more than 6 grams, it is abnormal. Usually it is attached to the posterior aspect of the thyroid, but sometimes you might find ectopic parathyroid glands, or you might find it embedded within the thyroid, or you might find it into the vascular sheath lateral to the thyroid. It secretes an important hormone, which is the parathyroid hormone, what we call the paras hormone, and it regulates the calcium level in the blood. It increases the calcium level in the blood. The blood supply of the parathyroid, mainly from the inferior thyroid artery, is not related to the thyroid because the thyroid is having a separate fascia and the parathyroid is having another fascia, but they are nearby. So this is why it is called the parathyroid, or the nearer to the thyroid. If you see the diagram, you will find the 2 lobes of the thyroid, one on the left, one on the right, and they are attached together in the middle line by the isthmus, and they are somehow related to the parathyroid. The inferior one is a little bit down and the superior one are with the dome of the thyroid gland. If you see them in the diagram, they look like this. 2 superior, 2 inferior, and they are a little bit of dark color than the thyroid, and then you can differentiate them by sight. Physiology of the parathyroid glands, they secrete an important hormone, which is the paras hormone, which is an 84 sequence of amino acids. The level usually is from 10 to 55 picogram per mils, and each lab is having its own level. So if you find a result of paras hormone, you have to ask the reference lab what is the reference level they are working with. This parathyroid hormone with others, they regulate the level of calcium in the blood. Paras hormone works on 3 sites. It works on the kidney to decrease the to increase the reabsorption of calcium from the urine, and it works on the intestine to increase the reabsorption of calcium, and it works on the bone and it stimulates the osteoclastic activity, so resorption of bone, and might lead to osteoporosis if it is excessive, and it inhibits the osteoclastic activity in bone. But in the three places, it acts like increasing the level of calcium in the blood. Other regulator of the blood calcium is the calcitonin, which is secreted by the parafollicular cells of the thyroid gland. At the kidney level, we said it will increase the calcium reabsorption, and if you give the diuretic, the loop diuretic, the calcium will be excreted more in the urine. This is why furosemide or Lasix is used in the treatment of hypercalcemia. On phosphorus, it acts in the reverse, but because it increases the secretion of phosphate in the urine, and so lowering the phosphorus level in the blood. The most important defect in the parathyroid, you can find hyperparathyroidism, hypothyroidism, you can find tumors or malignancies, you can find benign tumors which are adenomas, and you can find other problems which are of no surgical importance. The commonest surgical importance is the hyperparathyroidism, which is caused by several causes, which we are going to know in the way of describing this lecture. Hyperparathyroidism, we don't have a very accurate statistic here. In the United States, 100,000 cases were diagnosed or are diagnosed annually, and women are more affected than men. In each 4 patients, you will find 3 female and 1 male. Vitamin D level is 30 to 80 nanogram per mils, and paras hormone acts on vitamin D, and it changes from, in the kidney, it changes from an inactive form to an active form. Calcium level in the blood is 8.5 to 10.5 milligram per 100 mils, and it has to be regulated as that. If it increases more than that, it is hypercalcemia. And there are 3, we can divide hypercalcemia into 3 levels: mild hypercalcemia, moderate hypercalcemia, and severe hypercalcemia. And severe hypercalcemia could be an emergency because it have very bad consequences on the heart, and it can cause arrhythmias and cardiac arrest. Hyperparathyroidism, it is in 3 forms, and people always are confused about the 3 types of hyperparathyroidism. We have the most important one is the primary hyperparathyroidism, which is caused by either hyperplasia of the thyroid, that means increase in the number of cells in the parathyroid, and increasing the paras hormone secretion, or by a single adenoma in one of the 4 glands, and the adenoma will be active and secreting more parathyroid hormone, and by so doing it increases the calcium level in the blood, and this is what we call primary hyperparathyroidism. The third important cause, which can cause hyperparathyroidism in the early stages, is carcinoma of the parathyroid, which can secrete the hormone and increases the level of calcium in the blood and causes primary hyperthyroidism or hypercalcemia. I want you to differentiate this primary hyperparathyroidism clearly from the secondary hyperparathyroidism, which is caused by reduced blood level of calcium or low vitamin D, or mainly caused by chronic kidney disease. That means primary is caused by hyperplasia, adenoma, or carcinoma. That means the defect is within the gland itself. Secondary is caused by a feedback effect, that if there is low blood calcium, there is feedback to the thyroid that it will tell that the calcium is low, and then the gland will start to secrete parathyroid hormone. If there is low vitamin D also, it will cause low calcium, and it will cause the gland to work more. The most important cause of primary hyperparathyroidism, we said, is the chronic kidney disease, and usually this is associated with low calcium level, and it will cause feedback on the thyroid, on the parathyroid, and it will secrete parathormone. These are the two types which are common. The third type, which is the tertiary hyperparathyroidism, I want you to know it. The tertiary is a defect within the gland, but it is caused by a cause which is outside. For example, if there is chronic renal failure and the vitamin D is low, calcium is low, and there is a feedback to the parathyroid, it will start to increase the parathyroid hormone, and sometimes this feedback is with no break, and it will continue, and it will secrete parathyroid hormone, and it will continue unless it is treated. So you have to differentiate between primary hyperparathyroidism, second, which is primarily a disease of the thyroid itself, or the parathyroid itself, and secondary hyperparathyroidism, which is due to a feedback by low calcium level, and the tertiary one, which is an outbreak of the secondary one, the lesion is becoming like a primary one of the parathyroid. And these are the three types of hyperparathyroidism, and it has to be very clear and noted. Hyperparathyroidism can be diagnosed clinically if there is a swelling, or biologically or biochemically by seeing the calcium level, the parathormone level, the calcitonin level, and the bone density, the bone mineral density. How is it going on? If you want to diagnose the hyperparathyroidism, or disease of the parathyroid, earlier on the disease might be asymptomatic. In mild hypercalcemia, the disease might be asymptomatic. But if the level of calcium is increasing, then it will have general symptoms like fatigue, bone pain, joint pain, weakness, kidney stones, pyuria, abdominal pain, nausea and vomiting, and loss of appetite. These symptoms, which are sometimes vague, but it can be diagnosed early by doing the biochemical testing of the parathyroid. Examination may show or might not show any signs, but sometimes you might find abdominal tenderness, and in the examination of the neck, you might find a lump in the neck. Skin might be moist because of the sweating, and you might find an increased temperature. What are the investigations to be done in parathyroid diseases? The blood, as baseline, you have to do the CBC, the complete blood count, the parathyroid hormone level, which we said usually the level from 10 to 55 nanogram per mil. Calcium level is important, and usually the level of calcium is 8.5 to 10.5. If you find it increase more than that, 8.5 to 10.5 milligram per percent, or in millimole 2.5 to 3.5 millimole per liter, or still you can measure it in the 2 or 3 ways. Bone mineral density will give you that if there is, will diagnose the osteoporosis. Ultrasound can be done for the kidneys to see if there is any stone forming, or you can do it for the ultrasound for the neck to see if there is any parathyroid enlargement, one of the 4 glands. Methylene blue, also you can do it and you can see which part of the gland is active, and it will show you if there is an adenoma of the parathyroid. There is another scan which is called the technetium 99 scan, and it will show the activity of the parathyroid gland. There is another type of investigation which is called SPECT, single photon emission CT, and it is sensitive and it will show you what abnormality is there. Plain CT can be done, and also MRI or PET or positron emission tomography, which is also very sensitive in the diagnosis of parathyroid diseases. If you see the neck, you see the 2 thyroid lobes are there, and on the right side, or on the right side of the photo, you can see one of the lobes is removed with the 2 parathyroid glands, and you can see this is a very wide opening, which is not the classic opening of the surgery. For the operation, there is indication for surgery, and there is preoperative preparation, routine preoperative preparation like any other surgery. But what is different here is you have to localize the parathyroid gland before the surgery, and there are certain things you can localize the parathyroid gland. The classical approach is the collar approach, collar incision, and we also are going to talk about post-operative complications. Indication for surgery for the parathyroid: if there is a parathyroid adenoma, which is big, if it is more than 3 centimeters, surgery is indicated. Multiple parathyroid adenomas also is the indication for removal of the parathyroid. Parathyroid hyperplasia is the 3rd indication, and these are the 3 causes of primary hyperparathyroidism. Tertiary hyperparathyroidism also, if there are symptoms, you can you can do surgery, or you can do medical treatment first and then surgery. The definitive indication for parathyroid surgery is the appearance of malignancy. And biochemical indication, if the lab work is showing high parathyroid hormone, what we call parathormone, or high vitamin D, or high calcium, which we call hypercalcemia, and high phosphate, or there is, as we said, a large gland which is more than 3 centimeters. The American Association of Endocrinologists guidelines for who is a candidate for surgery. For example, calcium, if the level of calcium is more than 1 milligram per deciliter above the upper limit of normal, and we said the upper limit is 10.5, and if there is 1 milligram above the upper limit of normal, then this is an indication for surgery. Bone mineral density, which can be measured by DEXA. There are so many ways of measuring the bone density, mineral density, and if it is less than minus 2.5, this is an indication for surgery. And if there are fracture, especially fracture of the vertebral column, or there is a compression fracture of the vertebral column. Kidney, if there is kidney stones, or the creatinine clearance is less than 60 mils per minute, or if you are doing the 24-hour urine and the secretion of urine, the 24-hour secretion of calcium in the urine is more than 400 milligram per day. And as we said, if there is kidney stones on imaging. The age, usually we prefer to do surgery on patients who are fit and whose age is less than 50 years. But this will not deny the operation on old patients with malignancy. Other neurocognitive or neuropsychiatric symptoms, also they are indication for surgery for hyperparathyroidism. What are the pre-operative preparation of parathyroidectomy? Like any operation, the anesthetist should visit the patient on the day before or on the same day if it is becoming on local anesthesia. And the anesthesia itself can be local or general, as the preference of the surgeon. Preoperative localization is important. You have to do it before the surgery. You have to localize the 4 glands by so many methods, as we mentioned in the diagnosis and investigation of the parathyroid. Ultrasound, for example, will show you the density of the thyroid, and it will show you the parathyroid itself, which is separate from the thyroid gland. You can infuse methylene blue infusion, and then it will show you the 4 active parathyroid gland. Technetium-99 can be done, or as we said, single photon emission CT, or you can do computed tomography, or what we call PET tomography, positron emission tomography. Or you can do also MRI. So these are the investigation you can do to do the localization. The ultrasound, don't forget the methylene blue infusion, Don't forget the technetium 99 as indicator for the parathyroid. Don't forget the single photon emission, computed tomography, CT, plain CT can be done, or positron emission tomography, or even MRI can be done. On table, if you see the diagrams, the head must be rested on a pillow which is rounded, and the shoulders should be supported by a pillow also, and the neck is in semi-extended position. The classical incision is the thyroid incision, what we call collar incision, and it could be from 2 to 4 centimeters. And then you mobilize as you do thyroidectomy, you identify the inferior thyroid artery, and you identify the superior thyroid artery. You can ligate both of them. You can ligate the superior and the inferior thyroid. The middle thyroid vein, you can ligate it also, and then you have to mobilize the thyroid medially, and then you can see the two parathyroid, and you can take them. If for a benign condition like adenoma, multiple adenomas, or single adenoma, you can remove the adenoma itself, or if it is hyperplasia of all four, you can remove them all the four and take part of one of the parathyroid glands and implant it somewhere else. You can implant it in the neck, or you can implant it in the forearm. Surgery, we said there is a classic incision like the collar incision for thyroidectomy, or you can use the minimally invasive surgery, which is with a small incision, or even you can use video-assisted parathyroidectomy, or even you can use endoscopically. You can use the endoscope to visualize the thing. So you have 3 openings, one for the camera, one for the instrument, and there is another one for manipulation. The patient can be discharged on the same day if there is a lot of manipulation, and during surgery, frozen section can be done, and the level of parathormone can be done preoperatively, and intraoperatively can be done at 5 minutes, and at 15 minutes, and at 30 minutes, and see the drop in the level of parathormone. If the drop is 50% or more, that means the removal is complete. If still the parathormone is high, that means you have to do more surgery, you have to do more identification of the glands. Prognosis: in less invasive techniques, the recovery is very quick and is simple operation. We said hyperparathyroidism, it can be mild, it can be moderate, or can be severe. And in severe cases, the patient might have marked symptoms of abdominal pain, vomiting, dehydration, oliguria, muscular weakness, and it can lead to death. So, and serum calcium will be more than 12 mg/%. And this is an acute emergency. It entails emergency treatment of hypercalcemia. Emergency treatment of hypercalcemia in acute stage, you have to give a lot of fluid, because hypercalcemia will cause a lot of loss of fluids, and the patient will be might go into hypovolemia and he will be hypovolemic. And you have to give at the same time loop diuretics so that to increase the excretion of calcium. And you have to give calcitonin, which is reverse the action of parathormone. You can give chemical treatment by bisphosphonate or bisphosphone, and you can treat the cause by surgery, or you can reduce the level of calcium by doing dialysis. What are the post-operative complications? Post-operative complication, hyperparathyroidism or hypercalcemia may persist in 5% of patients, and this is a serious complication. Recurrent laryngeal nerve injury can occur as in thyroidectomy. Hyperparathyroidism, secondary hyperparathyroidism or hyperparathyroidism itself can occur later on. Infection of the incision, like any other operation, hemorrhage and infection can occur, and this is, it has to be clearly investigated. If you see this diagram, this is an incision, a collar incision, and there is a big hematoma as a complication of the surgery itself. And this is usually, it occurs even with thyroidectomy. So parathyroidectomy can give the same complication of thyroidectomy: recurrent laryngeal nerve injury, hematoma formation, and infection of the wound, and ugly keloid formation of the skin can occur from the incision itself. We will stop here and we will continue again our lecture. Thank you.